Good evening, everyone. The opening plenary session, we have transplantation in highly sensitized patients. Again, transplant in sensitized patients is very difficult, even before the transplant, even after the transplant, and maintaining the immunosuppression. To talk on this, we have 𝐃𝐞𝐜𝐡𝐮 𝐏 who is the Professor of Pediatrics, Director of Pediatric Nephrology and Transplant Immunology, 𝐶𝐻 Sinai Medical Center, Los Angeles, USA. I request Dr. 𝐃𝐞𝐜𝐡𝐮 to deliver his lecture. Thank you.
Hello. Thank you. I'm a little vertically challenged, as you all can see, so I'm just going to step a little bit off the stage, and hopefully you all can see me now. Many, many thanks to the organizers of the Indian Society of Organ Transplantation for having given me this opportunity to be here and in this wonderful city of joy. I'm just going to piggyback on what Dr. Sutantharan said. You know, regardless of the number of conferences we attend, nothing rivals as much as just being in India and being here amongst all of the colleagues that I know and love so much. Thank you. So I've been given this task of talking about transplantation in highly sensitized, challenges and recommendations. That's one of my passions that I've had, and I've been at 𝐶𝐻 Sinai for the last 23 years, and I've worked with such stalwarts like Dr. Stanley Jordan, whom I call my GOAT, my greatest of all times mentor. So a lot of what I'll be saying today is what I've learned from him, and also what I've learned from so many stalwarts who are amongst the audience today. They've definitely paved the path for everything that we know in transplantation. I first want to start by paying a little homage to the two biggest icons in my mind in the transplant world. In the dark suit is Dr. Joseph Murray, who performed the first kidney transplant among twins. And in the light suit is the first ever living kidney donor. He donated his kidney to his twin brother when he was, as you all know, about 23 years of age. I had the unique opportunity of meeting them. It was like meeting celebrities like Amitabh Bachchan or Shah Rukh Khan for me, right? Because they were the biggest stars for me in my transplant world. After them, we've had so many iconic people who've paved the way for transplantation, and I'm immensely humbled to be on the same stage as them today. So thank you again to the organizers. So the objectives of my talk will be a little introduction, which all of you are well aware of. We'll go through the first set of slides pretty quickly. We'll define sensitized patients. We'll talk a little bit about the etiologies for sensitization, challenges with being sensitized, overcoming barriers to sensitization. We'll talk a lot more about the protocols and the 𝐶𝐻 Sinai experience, a little bit about complications of transplantation after sensitization, monitoring during the post-transplant period, and some conclusions. The crux of my talk will really be to talk about protocols, which I am sure all of you are really interested in. So quickly, kidney transplantation, that's why we are all here, is the treatment of choice for patients with end-stage kidney disease and is associated with improved patient survival and better quality of life. However, there are several barriers to successful transplant. Organ shortage, we all know, is a huge barrier to transplantation. We find many anatomic barriers as well. The surgeons in the audience are well aware. And the third is the immunologic barriers. It was extremely fantastic, this whole session in the morning, where they talked about HLA and the various matches, mismatches. I am not going to pretend to be an immunologist at all. I am not. I'm a nephrologist, and I'm a transplant nephrologist. So all the sessions that we had in the morning will set the stage for what I'm going to talk about now. So we'll really talk about the immunological barriers to transplantation. Before we even delve into what we can do about sensitized patients, I just want to make sure that this audience, since you're from different halls and not just from the transplant immunology hall, understand a few key definitions that will help us talk more about how to overcome sensitization. The first one, of course, is something familiar to you all called panel reactive antibodies. It's a screening mechanism to detect HLA antibody profile of potential transplant recipients, where the recipient sera is added to a panel of HLA-type cells, and the sensitization is expressed as the percentage of serum reactivity with the total panel. So what about CPRA? So calculated PRA is the likelihood of transplantation determined by the single antigen bead, which we heard of in the morning, to identify the specificity of anti-HLA antibodies in combination with known frequencies of HLA antigens within the donor population. So what is important is if your PRA is 99% in India and your PRA is the same in the United States, the CPRA could be totally different because it really depends on the donor pool. And when we say 99% CPRA, what that means is that 99% of donors within that population are completely eliminated from being able to donate to that particular recipient who has a CPRA of 99%. So definition of sensitization, again, there isn't a clear-cut absolute definition of sensitization, but what I'm going to talk about a lot today is what we have defined at our center for all these years that we've done desensitization in our patients. So the general definition used is highly sensitized is a PRA of greater than 30%. We've introduced the term broadly sensitized, where the PRA is greater than 80%, because it's very different transplanting a patient with a PRA of greater than 30% versus greater than a PRA of 80%. So what are the etiologies of sensitization? Again, you all know prior transplant is one of the biggest etiologies. Prior blood transfusions for any reason. Pregnancy, especially multiparous pregnancies. And what we are seeing more and more of these days, and I don't know whether the rest of the audience sees this, is infections as a very important cause of sensitization, especially in our children who have posterior urethral valves, get recurrent pyelonephritis. They all can be highly sensitized without receiving a prior transplant. The challenges with sensitization are the inability to receive another transplant or being on the waiting list or languishing on dialysis for a really long period of time. And if a patient is given a transplant with a positive cross-match, very high risk for rejection and losing of the kidney. So there are many barriers to overcoming transplantation. The first one is kidney paired exchange or swap. I'm going to skip that topic because you're going to hear a fantastic lecture, 2 lectures from now, on kidney paired exchange. What I'm really going to focus on is desensitization or immunomodulation, or a combination of both. So this is my only slide on histocompatibility screening. Again, not an immunologist, cannot even pretend to be. But at least to set the stage for talking about overcoming barriers, I wanted to talk a little bit about panel reactive antibodies, which are the detection of a broad spectrum, detection against a broad spectrum of donors. So panel reactive antibodies are done only in the recipient. However, a cross-match is one that checks the donor-recipient pair. So it's looking for specific antibodies. It could be HLA, non-HLA, complement fixing, non-complement fixing. And in that, there are 2 big tests that we do. One is the CDC, which again, many of you have heard of this morning in the talks. And the other is the flow cytometric cross-match, which is labeled as mean channel shifts. So you'll hear us talking about CDC cross-match and flow cytometric cross-match represented by the mean channel shifts. The other thing that has been more recently being done is the single antibody testing on a Luminix platform, where you detect specific antibodies against donors. So the strength of the antibody against these antigens is expressed as mean fluorescent intensity, or MFI units. And at our center, again, all these things are very center specific. So you need to really talk to your friendly HLA staff about how to interpret the results that are given to you. At our center, an MFI greater than 5,000 is designated as unacceptable antigens. So one more concept that I wanted to introduce was the relative intensity score. So it's a scoring system used to quantify cumulative intensity of all DSAs at the time of transplant. So if you have strong DSAs, which is again in our center is greater than 10,000, it's given 10 points. Moderate DSAs are given 5 points, and weak DSAs are given 2 points. Again, that's the MFI cutoffs that we have. If you don't have DSAs, it's obviously 0. And what we published, me in pediatric transplants and Dr. Vo in the adult transplants, is that if you have a total point of 17 and over, you're at very high risk for antibody-mediated rejection, and we would not perform a transplant in that instance. So the whole premise of desensitization is to reduce panel reactive antibodies, decrease the flow cytometric cross-match, mean channel shifts, shorten the time to transplantation, so less time on dialysis, and permits transplantation in approximately 75 to 80% of highly sensitized patients. So this is, in my mind, the most important cartoon that you all should remember if you want to do desensitization. At the crux of it all is the B cell. So the B cell makes a lot of antibodies, and these are preformed antibodies. And just like I tell patients, these antibodies are like policeman cells. They're waiting, and as soon as an allograft is put, they're ready to attack the allograft, and the graft is dead, or there is rejection. So in order for us to proceed with a transplant in patients who have preformed antibodies, we do 3 things. One is, we try to remove these antibodies with plasmapheresis. 2, we suppress these antibodies with IVIG. And 3, we use a number of drugs that can prevent the formation of antibodies. These drugs are in 2 groups, if you will: monoclonal antibodies. In the end, you'll see MAB. And then MIPS, that stands for inhibitors or proteasome inhibitors. So there are many drugs that people have used, transplant physicians have used in order to suppress antibody production. And this has already been published, but the most important drug that we've used so far is rituximab. More than 80% of our highly sensitized patients have been able to be transplanted with a combination of IVIG and rituximab with or without plasmapheresis. Patients who have not been transplanted even with the use of rituximab, we've used tocilizumab, and I'll go into individual protocols for you. So the protocols, we've gone through a huge learning curve, and many times we've actually not done too well. So we've just gone off the road. And those are the ones that really have taught us what we can do better. And sometimes it's a very sort of a sad part to this whole thing that we do, even in medicine, trying new drugs and stuff like that. But sometimes it just has to be done for us to learn to do better. So the history of desensitization at Cedars-Sinai started in the year 1990 with, again, Dr. Stanley Jordan establishing these protocols. Initially, it was just IVIG, but we've since then moved on. And since 2005, we started using a combination of IVIG and rituximab. You'll see that along the way, there have been other drugs that have been used. But now the mainstay is IVIG and rituximab. And in the patients who don't get transplanted with that, we've moved on to tocilizumab. And I'll talk about some 2 experimental therapies that are in clinical trials at Cedars-Sinai towards the end. What we've actually learned from all the protocols that we've used, and of course, all the protocols that you will also read in the literature, is that one strategy alone is not enough. So using just IVIG is not enough. Using just plasmapheresis is not enough. So combination therapy works best. So all the protocols that you'll read in the literature from very, very eminent people in the field are a combination of different protocols that I've just said. So plasmapheresis with IVIG, with rituximab, with tocilizumab, with the daratumumab, with several other B-cell depleting drugs. So, and the protocols are all still evolving because we know that there is still incidence of antibody-mediated rejection in these transplants. So in order to control them, we need better protocols. In the year 2004, because of the interest in highly sensitized patients at our center, we established the transplant immunotherapy program. This is a combination of people interested in desensitization, transplant physicians, along with our transplant immunology lab and our HLA lab. We meet once a month. We talk about all the patients who've been presented who are highly sensitized, and based on their sensitization status, decide what protocol we need to use for desensitization. We've done, since that inception of the transplant immunotherapy program, we've done about 3,000 transplants, and more than a third of the transplants have been on highly sensitized patients. This slide is not for you to be able to even see. I just put it there because this is published. It's the protocol that we use, and I'm going to walk you through that. So if you have a patient with a CPRA of greater than 30, whom in our center we call highly sensitized, they're listed first for a deceased donor, and then the patient is asked if they have a living donor or not. If they have a living donor, we follow the green pathway. If they don't have a living donor, we follow the blue pathway. So what are these pathways? So if they have a living donor, there are three possibilities. Either they have a positive CDC, a negative CDC and a positive flow, or a negative CDC and a negative flow. If they have a positive CDC, we try not to desensitize them at all, because there have been a lot of incidents of acute rejection in patients who are transplanted across a positive CDC. So we evaluate for other potential donors, or we pursue paired exchange. If they have a negative CDC and a negative flow, these patients still undergo desensitization. Obviously, they have something going on because that's what their CPRA is greater than 30. And then if they have an acceptable cross-match, we proceed with transplant. If they don't have an acceptable cross-match, we think about other desensitization therapies or paired exchange. Now, if they have a negative CDC cross-match and a positive flow, we look at the strength of the cross-match. So if the cross-match is greater than or less than 250 mean channel shifts, and the relative intensity score of the DSAs is less than 17, then we definitely perform desensitization in these patients, usually with IVIG and rituximab, repeat cross-match. If the cross-match is acceptable, we proceed with transplant. However, if their strength of their cross-match is greater than 250 mean channel shifts, or their relative intensity score is greater than 17, then we do not perform desensitization. Again, offer them other living donors or paired exchange. What about the blue protocol, where they have deceased donors, where there are no living donors, obviously? So if the offer is likely to come in within the first year, then we perform desensitization with IVIG and Ritux. If they are transplanted within 6 months, then routine post-transplant monitoring. If they are not transplanted within 6 months, they go through desensitization for the second time, usually with plasmapheresis, IVIG, and Ritux. Again, they would be transplanted within 6 months. Great. If they are not, they offered alternative desensitization therapies. In our center, it would be plasmapheresis, IVIG, and tocilizumab. If they are not likely to be transplanted within the first year, then they remain on the list till they come up to that point where they are likely to get offers. One thing that I want to bring to your attention is the whole premise of the acceptable cross-match. So we all know that a positive cross-match at the time of transplant is associated with very poor outcomes. So immunomodulation, when we do desensitization, it reduces the alloantibody titers to a level that's sufficient to get an acceptable cross-match that allows for transplantation with a low risk for AMR. And we know that C1q positive and strong DSAs are very difficult to bring to acceptable levels. At our center, a negative cross-match is a flow cytometric cross-match less than 130 mean channel shifts and a B of less than 70. However, studies done at our center have determined that you can take kidneys with an acceptable cross-match where it is less than 250 mean channel shifts for both T and B. This again is published, and so a lot of our highly sensitized patients do not have a negative cross-match, but they have an acceptable cross-match, and we are able to perform a transplant under cover of alemtuzumab induction therapy. When alemtuzumab is not available, ATG can also be used for induction. So this is our first protocol where we have rituximab given week 0 and week 2, IVIG given week 3 and week 6. We wait for an acceptable offer. When we get an acceptable offer, alemtuzumab induction with triple immunosuppression. If they are not transplanted or if their CPRA is greater than 99%, these are the most difficult patients, we do plasmapheresis, IVIG, and rituximab. Again, same thing, wait for an offer, acceptable offer, they get alemtuzumab induction and triple immunosuppression. And at the time of transplant, these patients get IVIG or rituximab if it's been more than 4 weeks since they have received it. The third protocol is with tocilizumab. So they get plasmapheresis, IVIG, and monthly tocilizumab, and then they wait for offer. So the monthly tocilizumab is for 6 months. So I wanted to just, in the last few minutes, talk about investigational therapies that are coming down the pipeline. The first one is a drug called 𝐼DIS. 𝐼DIS is sort of the newest kid on the block, if you will, in terms of drugs used for desensitization. This is a very unique drug, and it was discovered very serendipitously. So it's an enzyme that's made by Streptococcus pyogenes, a common bacteria. And this enzyme actually cleaves IgG into its Fab and Fc fragments and renders it completely inactive. So when you give 𝐼DIS, you can see in red is the level of antibodies before receiving 𝐼DIS, and in blue is the level of antibodies after receiving 𝐼DIS. Above, the graph above shows you 6 hours after receiving 𝐼DIS, and the graph below shows you 1 hour after receiving 𝐼DIS, and you can see that these antibodies are completely abrogated. So at that time, we give them a transplant and then continue with our traditional 3-drug immunosuppression and give them alemtuzumab. The next investigational drug that is going on clinical trials right now is the chimeric antigen receptor T cells, or the CAR T cells. So we've all heard about the CAR T cells in the oncology world. We've started to bring this. In fact, a lot of the drugs that we use in the transplant world are drugs that have been used in the immunology world. For a different reason, we've brought it to our transplant world. And this is one of the, again, new things that's coming into transplant. So what this is called the Regeneron study, where you give them a bispecific CAR T therapy, something that attacks both the T cells and the B cells. And these are only for patients who are awaiting deceased donor transplants. The inclusion criteria is they need to be having greater than 99.9% CPRA. So these are the toughest patients to even be able to transplant. So those are the patients who are enrolled in this study. And this drug is given with an IV infusion. Patients are admitted to the hospital. And so far, 3 patients have been admitted. None of them have yet gotten a transplant, but this is just a very fresh study that has just been started. So what are the complications of all of this? So many drugs. So one of the important complications is rejection. Inherently at risk for rejection compared with patients who receive a compatible transplant, obviously. And the risk of rejection is increased in parallel with the degree of incompatibility. So 18% in DSA positive, negative flow cross-match patient, and it gets higher as the cross-match gets more positive. And it's mostly antibody-mediated rejection. And the next one is infections. We used to think that there'd be a lot of infections in these patients because of all the drugs that we use. However, in pediatrics and in the adult patients, there's enough literature that's been published that shows that the incidence of infections is not that high. It's the same, it's comparable. There is a paper that we have published in pediatrics looking at alemtuzumab, and the infection risk is really comparable. I really think it's because we use so much IVIG as well, which is passive immunity against infections. We always give them prophylaxis, both for PCP, for antiviral, and for antifungal prophylaxis. This is our prophylaxis strategy that we use. No overall risk of malignancy, which is really heartening. So outcomes of HLA incompatible transplant. So it's a difficult decision to proceed with HLA incompatible transplant rather than to wait longer for a more suitable donor. We all face that dilemma. Several cases were presented earlier as well. Given that, excess mortality is observed on dialysis compared with those on transplant, but in every patient population, the long-term risk of death is lower in transplants compared with dialysis. So really, transplantation is a very good strategy, but you have to monitor these patients post-transplant. This is our monitoring strategy. Dr. Sutantharan gave an excellent lecture on post-transplant monitoring. I'm happy to share our monitoring strategy with you. We do cell-free DNA in all of our patients. That's one of the ways we monitor. And I just wanted to end with 2 slides. I worked very closely with IKDRC. They had a number of highly sensitized patients. We did Zoom calls. We talked about desensitization. And when I visited Ahmedabad last year, it was very gratifying to see that 11 of these patients got a successful transplant. This was, the best moment for me in my desensitization journey. Long-term graft and patient survival are comparable. I just want to end with these acknowledgements. First of all, to the HLA lab, the transplant immunology lab, renal pathology, my, like I said, greatest of all time mentor, Dr. Jordan. And really, most importantly, to our patients, I really have to acknowledge the faith that they have in us as we bring in new therapies and try to do better in our success in transplanting these difficult patients. I want to leave you with a slide with it's a needle point that I did. Well, I hope I can, a needle point that I do needle point as a hobby. So this is a needle point that I did. 2 organs that are very close to my heart, literally. Thank you so much.
Thank you.
Thank you. Thank you, Dr. Dichu Pulienda. Wonderful lecture. And the very tough topic, and you have elicited how to reduce the titer. My one question is, post-transplant, how frequently you monitor the DSA? And if they get a rejection, because they have treated so much, and if they get a rejection, then what is the plan for ABMR treatment?
Great, thank you, sir. So yes, we monitor DSAs. We start actually at the 3-month mark because we anticipate the DSAs to start forming a little later. So we start at the 3-month mark. We do 3 months and 6 months. And if they have negative DSAs, then we do it every 6 months after transplant. If DSAs do come up, we actually look at the serum creatinine, we look at our cell-free DNA levels, and we have a low threshold to actually do a biopsy on them. If patients have an antibody-mediated rejection, which is the most commonest of the rejections that you'll see, we treat them again with IVIG and rituximab. That's our protocol. And if the rejection is persistent, despite IVIG and rituximab, we treat them with monthly tocilizumab, and that's been published, sir.
Even those who have treated with tocilizumab prior to the transplant, where the CR, you will continue the tocilizumab post-transplant?
Yes, we do continue tocilizumab for the first 6 months after transplant. Thank you, sir.
Thank you very much. House is open for questions.
Please.
Stephen Martz from London. Thank you very much indeed for a wonderful talk. Very enlightening. I just wanted to ask you about BK viremia and BK viral-associated nephropathy, because you said there was no increase in infection rate, but we have seen an increase in the number of BK viremia. And also I noticed in your monitoring, you don't monitor BK very often compared to CMV viremia. I think it was...
No, we do monitor BK. BK viremia is a known complication that all of us see, the dreaded virus. For the first year after transplant, we monitor BK virus, CMV, and EBV every month for the first year after transplant, because most of the time, the appearance of these viruses is within the first year. So if we see BK viremia, the initial strategy, again, BK viremia is a whole talk in and of itself, we definitely reduce immunosuppression, very gingerly, I must say, but we're very quick to use IVIG in these patients, because IVIG, as you know, is not only a passive, immunogen against BK, but it's also an immunomodulator. So you're less likely perhaps to get DSAs as you're reducing immunosuppression. So we use IVIG pretty quickly, especially in our highly sensitized patients with BK viremia, reduce immunosuppression. And we've successfully treated a number of patients with BK viremia with leflunomide. So that's another strategy that we use.
Yeah, no, we've also tried leflunomide, but again, we didn't find much success. So I'm pleased that you're doing better. Thank you.
I think it's a mixed bag with leflunomide, but yes, we've definitely had some success with it.
Thank you very much.
All right,
You're
with that, we would like to thank our chairperson and felicitate. I request Dr. Pratik Das, sir, to please join us on the stage and felicitate chairperson and our speaker as well. A small token of appreciation.